Hello, I'm Dr. J Randall Curtis. I'm director of the Cambia Palliative Care Center of Excellence at the University of Washington. And my topic today is palliative care in the ICU during the COVID-19 pandemic. I have no financial conflicts of interest to disclose. I do like to acknowledge our funding sources, including our healthcare system, UW-Medicine, the Cambia Health Foundation, the National Institutes of Health, and PCORI. What I'm going to discuss here is a little bit about advanced care planning and goals of care discussions, modifications to these ideas for the COVID-19 pandemic, and then finally palliative care during the COVID-19 pandemic, particularly supporting family and the role of palliative care specialists. These terms get used differently by different people, but I think of advanced care planning as discussions about values, goals, and preferences for future care for healthy individuals, and goals of care discussions as a subset of advanced care planning, where we're talking about current goals and how they should inform current and future care. And that may be in patients with chronic illness, early goals of care discussions, or in the critically ill or imminently dying, late goals of care discussions. In the ICU, we focus on and spend a lot of our time talking with families, mostly of critically ill, about their goals of care, what I would consider late goals of care discussions. I'd also like to briefly talk about the definition of palliative care. Palliative care is really a very broad concept around care provided to patients with life-limiting or life-threatening illnesses that includes symptom control, physical and psychological, as well as communication, coordination, and spiritual care. We can think of this as primary palliative care, care provided by all clinicians in the ICU who care for patients with serious or life-threatening illness, as well as specialty palliative care provided by palliative care specialists. So how do we change the way we think about this during the COVID-19? What's different about our fundamental approach during the pandemic? I would argue nothing. The pandemic certainly has a great impact on how we deliver care, but it really shouldn't change our fundamental approach, for the most part, for how we care for critically ill patients. Now that's true as long as we're not hitting the crisis standards of care. We can think of three levels of care: conventional care, which is the care we were providing before the pandemic. Many of us have been in contingency care, where our healthcare system and our ICUs are stressed, but we're striving for usual care under this stress. And then finally, crisis standards of care, where our scarces are limited and we have to modify the way we provide care. These issues around how we care and how we provide palliative care would change in crisis, but shouldn't really change during contingency standards of care. Most of us, fortunately, have not been and are not in crisis standards of care, and we've mostly been able to avoid that through public health measures like social distancing, wearing masks, and so forth. If we do hit crisis standards of care at any time during this pandemic, then things do change. Hospital triage teams need to make allocation decisions. Use of CPR and the intensive care unit, the use of mechanical ventilators obviously would be included in many of those decisions. We wrote a paper in JAMA at the beginning of the pandemic about the importance of addressing advanced care planning and decisions not to resuscitate during the pandemic, arguing that the COVID-19 has heightened the importance of advanced care planning and goals of care discussions and has introduced a key role for both primary palliative care and specialty palliative care during this pandemic. And in specialty palliative care can be tapped to help teach, coach, and support the provision of palliative care in these times of stress. We also laid out a proposed model for implementing informed assent as one way to think about having discussions about CPR for critically ill patients with COVID-19. The idea behind this is that non-beneficial or unwanted CPR has always had risks for patients and families, can prolong patient suffering and increase family distress. And during COVID-19, CPR may actually increase risk for clinicians as well, increase potential for exposure, increase clinician distress, and increase use of limited PPE resources during times of particular strain. In addition, CPR is likely to be less effective when patients are in isolation and the team delivering CPR has to get into PPE before they can start delivering CPR and ACLS. The idea here is that with informed assent is that we need not discuss therapies that are not indicated, but CPR is often an exception because of patient and family expectations for CPR. Family members may even be trained in CPR and really understand what it is. And in this situation, informed assent is an ethical option where we can help patients and families who have difficulty making a decision, but will let us decide. The idea in this approach is to assess the patient's values. There are those out there who are vitalists, that life is worth living at all, no matter what quality of life, and they may not be appropriate for this approach. But if they're not vitalists, then we would proceed with informed assent, describe CPR, explain why in this situation, CPR really won't help us achieve the patient's goals, and then make an assent statement. In this situation, we don't use CPR, allowing family members, in this case, to make sure that they understand and have the opportunity to object. If they do object, we enter into additional negotiations and try to work on building trust and supporting the family. If patients are vitalists, informed assent's not appropriate, and in that situation, where CPR would really be truly futile, and we would consider a unilateral DNR in that circumstance. And unilateral DNRs are used and legal and allowable in some areas and not in others. That there's a lot of regional variability there. So then finally, talking a little bit about palliative care during the pandemic, I think our experience suggests that it's really important that we support families and that we not underestimate the stress that this pandemic has caused on patients, families, and clinicians. We need to identify alternate forms of communication in our ICU for our patients with COVID-19, where the families can't come and visit. The team makes a daily phone call. The doctors do to the family. The nurses also make a daily phone call. And then we also offer video conferencing, either with the team and the family, or often as well with the patient and the family, so they can see their loved one. We also do create opportunities to allow families to see patients. They can come into the ICU and see the patient through the window to see that they are comfortable, often on the ventilator and not able to interact, but at least they can see they're comfortable. And then when patients are dying, we do allow 1 or 2 family members into the room in PPE. They're helped in by nurses and can spend some time with their family member. We developed this palliative care response plan at the UW-Medicine, where we laid out the ways in which the palliative care team could provide some additional support in the conventional capacity, contingency capacity, where we spent much of the spring and still find ourselves in, as well as in crisis capacity, where we at our institution did not hit crisis capacity. The idea behind this plan is that palliative care consults are ready to help, prioritizing high-need patients and families, particularly COVID-19 in the ICU and in the emergency department. They're also available for coaching and brief or full consults, and have an explicit plan to surge up palliative care providers if that's needed. The areas where palliative care providers have been particularly helpful have been difficult goals of care conversations and code status conversations, supporting patients with moderate or severe symptoms that have been difficult to manage, and then also spiritual assessment and support. It's also been very helpful to have palliative care as another voice to reach out to families so that they can really feel like they're hearing what's happening. In addition to the ICU team, palliative care will also make calls to the family and sometimes have video conferences. We developed this prognostic communication tool early on in the pandemic. We found that there was a lot of confusion about the prognosis for patients with COVID-19 who were intubated. And so this was used to help clinicians be a little more consistent in the way that they communicated. And we really divided this into two major groups. Group one was patients who were generally less than 60 to 70 years and only lung involvement, where the survival was significantly better from acute respiratory failure in COVID-19. And then group two was those who were generally over 70 and or had multiple organ involvement. And we update this regularly, but it's just a way to help clinicians have some consistency in the way they talk about prognosis with the families. There are a number of resources that are available around COVID-19 and palliative care that I think are helpful to be aware of. The Vital Talk organization has a COVID-ready communication skills. And then there are also some resources facing patients and families, friends and relatives around having these discussions, the Conversation Project and Prepare for Your Care, both of which have COVID-19 specific components. With that, I'll stop and thank you very much.